Thank you very much, sir. I think uh, at the outset, I would like to thank the Karnataka Orthopaedic Association for having such a program, webinar, and that too, foot and ankle, and to top it all, specifically about the flat foot. I think something which all of us are currently seeing. I think it's if you can just notice. I think even this the current issue of the Journal of Foot and Ankle Surgery, Asia Pacific. That's the Journal of the Indian Foot and Ankle Society. The has run a symposium on the pes planus only. So it is something which has gathered the attention of people for the reason being that it's quite painful. I think it's not necessary that the flat foot is always painless. There are many patients who have flat foot which is very painful, and which is the reason I said we would title this as pes planus. Ouch! It hurts. So that's the whole topic of the webinar, and the whole program we scheduled it in such a way that we are looking at most of the things. We would not touch upon the pediatric foot because we would be more on to the adolescent. We'd start off with the adolescent pes planus, then we the different types of the adolescent pes planus, and then on Krishna would speak on the adult acquired flat foot, some conservative options for that, and Dr. Lucas from Poland would speak about the adult acquired flat foot, some surgical options for management. And Dr. Graham, of course, who's the innovator of the extraosseous tarotarsus stabilization implant called the Hypercure, and he would be speaking to us about the implant per se, and also the biomechanics behind the design as well as the biomechanics behind the pes planus. So to top everything all, we also have lots of cases we would be interspersed in between. I think the plan we had was first two would be the talks about the adolescent and the adult, then a few cases to be discussed, and then on we would have talks about the adult surgical as well as the EOTTS. So it's exactly 7:30, so I think maybe we should start off. And as and when I think discussions, I think as per the regular format what we have with regard to the KO webinars, I think we will have the discussions in the same format. And let me just start off. My screen visible, and am I audible?
Yes, sir. It's
Yes.
visible.
Okay. Right. I'll just go on to the slide. Okay. So, with regard to the adolescent pes planus, I think there are so many things that we need to know. So, first and foremost of all, we see a child maybe about 13 years old in a clinic like this. So, this is what he is looking like, but this is what his foot is like. So, is this the same as this? This is 11 or 12-year-old boy, and is also having a pes planus. So these are the adolescents who are having pes planus. There's a lot of difference between both these feet, and this is what I thought we would just address in this small talk, which I'm going to share with you all now. So that would be the overview. So let's define a pes planus. We would find the magnitude of the problem which is there. We would look at what are the causes which cause the pes planus, and what are the clinical features, how we assess them, and what would be the managing options for all of them. So flat foot by definition is a condition where the medial longitudinal arch of the foot is lost. So that's the simplest definition. So, and with it associated are, there's a hindfoot valgus, there's a midfoot abduction, and the forefoot can either be pronated or supinated. It differs on different patients, and the Achilles is tightened. So these are the associated symptoms along with pes planus, especially in the case of an adolescent. So most of the feet are flat physiologically when a child is born. I think then only when about the age of 2 to 3 years the arch starts to develop, and almost 10 years the development of the arch is complete. So after the ages of that, so if you're looking at a patient in the adolescence, somewhere in the 12 or 14 years of age group, you will find that all of them would be having an arch. But there are instances wherein this is not there. And these are the patients we would be calling as the patients with an adolescent pes planus or adolescent flat foot. So most of the literature demonstrates that this is in the 9 to 13 years of age group and also in adults. So we actually had a incident study which we had conducted, wherein we had evaluated 323 students in the age group of 14 to 16 years. We had identified them from schools which are just adjacent to the institution where I work at the Ramaya Medical College, and Dr. Jagdish, had done this as a student program, as a student project, and he had identified that the incidence of pest planus was extremely large. Now we have sent this for publication, and it is under process for publication now. And but the findings of this were that the ratio of the male to female incidence of a pest planus is about 5 to 3, and there are about 32% of the children in that population or adolescents in that population who have a pes planus. So it is significantly high, and this is something which was completely as a shocker, which came to all of us, because if we go through all the literature which has been published hence prior to this, we found that people have been giving instances of about 4% at 10 years, of about 16% at 14 to 20 years, like that. And at this age group, it was just about 0.69% according to one of the studies in Italy. And so when we found this to be about 31.6, we were actually quite surprised, and we tried to evaluate what were the causes for this. And that is currently going on as a second study, and which is right now underway in our institution. But then we found that that's the incidence, and among this, it's predominantly the flexible pest planus, which is more common. The rigid variety, or the one which would definitely need some kind of a treatment, is only about 5%. So that's the exact statistics for us, and that's the magnitude of the problem that we have. So almost a third of the population in the age group of 14 to 16 would probably be having pest planus. Of them, a significant number would be painful, and they would be the ones which we would have to address and find some solutions for them and prevent them from going into so many other things. I think it's just because what does happen is, if the adolescent develops pain, they tend to withdraw themselves. They stay away from playing games, and there are so many other factors to it. So there's it's the mental makeup. Everything changes. So I think it's ideal that we identify these patients at the earliest, and then on start off with treatment for them. So like I told you, there's two major subclassifications we have. Either it's flexible or it is rigid. And how do we differentiate between the two? A flexible pes planus is the one wherein when the patient is standing or is bearing weight, there's no arch, or the arch is completely obliterated. But if the patient is non-weight bearing, it's the same child, and if he is just non-weight bearing, you can see the development of an arch. So this is a flexible pes planus, and the causes for these are varied. So it could be predominantly the that the ligaments should be lax, or the tibialis posterior might not be acting very well, or might be acting but it might be slightly elongated. So all these are factors to this, and these could be addressed very often conservatively. But then we also need to address the reason for this flexible pes planus. So some of them would be having recurrent talotarsal dislocation. So these are the cases which, and these are the exact patients whom Dr. Graham would be speaking to us about. And I don't want to steal his thunder from that. So we would be discussing about that in Dr. Graham's talk. But suffice us to know that there is something called as a flexible pes planus, wherein an arch forms on non-weight bearing, and a rigid place planus where the arch continues to be absent even when the patient is non-weight bearing. So what I have shown here is the performance of a heel raise. So this is one of the tests that we can use to differentiate between a flexible and a rigid pes planus. Generally, it is done on a single leg stance. The person with the involved foot is kept on the floor, other foot is taken off the floor, and then a single heel raise is performed. So just I have this picture here just to show to you the difference between a positive and a negative test. So this will be negative, wherein once the heel is raised, the hind foot goes into a varus. So normally on weight bearing, it's in valgus, but on doing a single heel raise, it is going to turn into a varus. Whereas in the case of a rigid pes plenus, it is going to stay in the same form. It is going to remain as a in a valgus position and not come back. So this are the pathological pes plenus, or these are the rigid pes plenus. These are the ones which definitely would need some kind of a treatment. And differentiating this from the very beginning by a simple clinical test performed in the clinics, I think is going to help save a lot of children from going into so many other complications in further in life. So, what is the most common cause for a rigid pes planus? It's a tarsal coalition. A tarsal coalition is an abnormal connection which is there between the two tarsal bones, and very often this is due to the failure of separation of the mesenchymal soft tissue, mesenchymal separation between the tarsal bones, and this happens during the embryological development itself. So, the common types of coalitions that we have encountered are the calcaneo-navicular coalition and the talocalcaneal coalition. And I'll be just showing you a couple of cases related to that in this same talk. So the associated deformities in these would be the flattening of the arch, and there would be abduction of the forefoot. The valgus hindfoot is seen, exactly the case which I showed you. And there is very often a peroneal spasticity. So this uh, the peroneal spastic kind of a foot which we do encounter in is very common in this age group, and that's something which is very resistant to treatment also very often. So these are the types of coalition that we have. So we can either have a based on the anatomic types, they can either be a talocalcaneal coalition or a calcaneo-navicular coalition, this being more common of the two. And the pathological types could either be a fibrous, wherein there would be a syndesmotic kind of an involvement, or it could be cartilaginous, where it would be a synchondrous kind of an involvement, or a bony, where it would be it's a proper bony connection which is existing between the uh, tarsal bones per se. So this is patients sometimes can be very asymptomatic, and very they can be, but then if there is something, pain can be the most common symptom that we see, and the flat foot also is a most common symptom or a presentation that we see. So the pain is the most common symptom, and flat foot is the most common presentation to us at the adolescent age group. And the causes for pain are varied. So it could be an ossification of the previously fibrous or cartilaginous coalition, which is there. Then there could be microfracture at the coalition bone interface. There could be secondary chondral damages or degenerative changes which happen in the joints, and they could lead to pain. Or sometimes there could be an increased stress on the other hindfoot joints, and this could be the site of pain. So whenever we evaluate the child or the adolescent, it is ideal to go through all of this, try to identify the site of the pain, and design our treatment according to that. So each one of them needs a different thing. So if there is, it's due to increased hindfoot stress on the other hindfoot joints, we could just manage with some kind of a conservative support. If there is already chondral damage or degenerative changes, we might need to plan in for some kind of a fusion. And if there's just a microfracture, I think these could be the children wherein we can plan for some kind of an excision. So that's what is going to decide for us. The site of the pain is going to decide for us what should be the treatment that we plan for. So that's the where the patient would have their pain. They would have either at the synesthesia region, or they could be having it on the medial side. They will point out the pain to us, and on that we can the findings that we do see is there's a limited range of movement at the subtalar joint. And we of course take weight bearing x-rays, and on after taking the weight bearing x-rays we are going to see what is there. And very often the talus is going to be looking down like this. The declination of the talus would be there, and the talus first metatarsal angles would be changed. So these are the things that we look for on the X-ray. And of course, the normal bony architecture is always obliterated, and so we can either look for the even the fibrous or a bony coalition like that. So this has been likened to that, and in case of a talocalcaneal, or if even in case of a calcaneal, the other thing that we can see on a lateral radiograph is some kind of a beaking of the talus. If you look at it, it looks like a beak. So this is the other thing that is seen in case it's one of the secondary signs of coalition, and if it is there, then a coalition should always be suspected. And there is also called as an antitrust sign, which we can see, and Here you can see that the shape of the foot of the coalition looks like that of an anteater's nose. So that's called an anteater nose sign. That is seen in case of a coalition, a calcaneonavicular coalition. One of my patients with a calcaneonavicular coalition. And in case of a talocalcaneal coalition, we have these kinds. So wherein normally you can see that the talus and the calcaneus are at the septalar joint, and the medial facet is going to form such a nice, good semi-lunar kind of a tracing. Whereas in the case of a coalition, you can see that there's a double shadow which you can see here. So this is not pathognomonic for a talocalcaneal coalition, but then this is very often seen, and this almost also sometimes looks like a boomerang too, but it is called the C sign. But this is the most common sign that you can find on an X-ray. So you can also find that the septalar joints are quite narrowed down. So you can see that the talus is extending right all the way up till there. And the medial facet is not seen at all. You can only see the lateral facet here. The medial facet is not seen only. The posterior is seen, sorry. The medial facet is not seen at all. So obliteration of the medial facet and all these obliteration of the concavity of the talar neck, all of these are features of a talocalcaneal coalition. Other views that we can take a Harris axial view, which can also be pathognomonic for a talocalcaneal medial facet coalition. So this is what we look for. So normally when we take an X-ray in the axial view, we are going to see the septalar joint and the facets very clearly. Whereas in this case, you cannot see the sustentaculum at all. So whole the sustentaculum as well as the talus is formed as one single piece. So that is the coalition that we can appreciate. A CT scan also can be very informative, and we have seen that on the CT scan on coronal sections. You can see if there's a bony coalition, and on an MRI you can see a fibrous coalition. And this is the again the beaking that you can see. This is one of the another patients where I had seen got a accident, and this is an MRI which we can see if there's a bony coalition. You can also appreciate that. I have a picture with the fibrous coalition also. So this is the patient with a bony coalition. This is the CT scan. You can see that the calcaneus and the talus here are in one single view. So there's complete continuity. So it's a rigid bony coalition. So this patient had a significant pes planus, and he was quite symptomatic also. That's the fibrous coalition which we can see on a MRI. So calcaneonavicular coalitions there, and the talocalcaneal coalitions here. Okay. So management would be based on the age at which they are presenting to us, their symptom signs, and what's the type of coalition and what demands the patient has. So very often we go in for a conservative option or a surgical option. The conservative options would just include using of a UCBL with a medial wedge. So this is going to realign the foot itself, and once that happens, the pain would subside. And once the pain subsides, the children are quite happy, and they continue with most of the activities that they do. But the ones who are resistant are the ones who have a definite rigid coalition, the ones who are extremely symptomatic, and who have a positive single heel raise test like this. I think we should go in for planning for us. After the due evaluation of these patients, again you can see that there's a definite coalition over here. And after that we have done that, so we go in for a surgical option wherein we are going to excise the coalition here. So you can see the coalition which is there in this case, and which after excision you can see that the medial facet is completely freed up. That's the tip post which I've lifted up, and you can see that the facet is completely freed up, and there is a good range of movement which has happened. So this is what I did in this case. I also supplemented it by means of an EOTTS so that I could prevent this from recurring and allowing the child to go in for a normal foot rather than going for a pes planus, this child. So at about 6 weeks follow up, this is what he's healed up like, and he has come, and he's though that's you can see that the uh, aspects of the valgus and all of the heat is completely corrected, and it's almost near neutral on both the sides. He still is not able to perform a single heel raise. I had just about seen him within 6 weeks. So that's one of the reasons he was not able to do that. And those are his X-rays at 6 weeks. We can see that the arch is completely restored. You can see that it's the same patient. You can see that the calcaneal pitch angle has come back. You can see that the talus with the first metatarsal angle has come back. The declination is no longer there, and there is a nice arch which has developed in this case, and it is developing further. So as and when he grows up more, he'll improve. The flexible pes planus is very often asymptomatic, in which case it can be managed conservatively by just giving some tender Achilles stretches and all that. And if they're symptomatic, there are surgical options for that. One of them being a sinus tarsi implant, about which we will know more about. So this is one patient I had operated upon in April of 2018, and you can see this child when he came back to for follow up after 2 years. Last March to 2020 March, he came back to me, and you can see the difference which has happened to his foot. You can see the shape of this foot. This is the side which I operated upon. You can see the shape of the foot and the width of the foot. So this looks very, very flat. This looks wide also. And this, the arch has already formed. So you can, overall, you can make out the difference between the two. And it was like a comparative study for me to show whenever. So I use this slide whenever I'm making a presentation. So that's the arch which was developed, and that's the flexible pes planus which is there on the opposite side, and which would probably, and for whom I operated upon, and he went on to use. So thank you very much. I think I'll leave you with this, and this is when we had got the pleasure of welcoming both Dr. Lucas and Dr. Graham to our institution when they had come in last, it was last January 12th, when they declared the Rameo Hospital and this thing as a center of excellence. So that's at that time. So thank you all so much. Can I request, I'll unshare my slides now. And can I request,
Dr. Ajay, you have a question.
yes, sir.
Shankar is asking, is there increased incidence of flat foot in adolescents due to the increased incidence of obesity in children?
Obesity and pes planus is something we studied, and our study, which I told you we are publishing it, we found absolutely no correlation between the BMI and the incidence of the pes planus. There's absolutely no incidence between the two. There's no correlation.
Thank you, Dr. Ajay. We can go with the next talk. What do you want to do?
Yeah, I think Dr. Krishna would be speaking about the conservative options in case of adult acquired pes planus.
Do the panelists have any questions to ask? Dr. Mallikarjun sir, Dr. Wali sir?
Ajay sir, my screen is seen and
Yes.
my voice is heard, right?
Yes, very clear, loud and clear.
Yeah, thanks. At this outset, I would like to thank the Karnataka Orthopaedic Association to give this opportunity to talk about the conservative approach to adult acquired flat foot. Does it work? Greetings from Kasturba Medical College, Manipal Academy of Higher Education University to all. Now, my talk is finding an answer whether what are the specific indications for a conservative management in an adult acquired flat foot, and what is a conservative managed per se, and what the literature say presently, and what is our approach in the Indian scenario. So we would like in the end want to find answers for this. And my talk is based on two sections. First section, where the adult acquired flat foot is defined and how they clinically present and how to come to a diagnosis, we'll be looking at. The second, how we manage conservatively is the second part. Now, adult acquired flat feet, as simple as collapse of the medial longitudinal arch after achieving the normal skeletal maturity. What happens? The posteromedial structures are stretched or are broken, leading to collapsed medial arch. Now, this loss of development of arch is seen normally in 15% of the population, but only 7 to 15% out of which are present with symptoms. Now, in a case of an adult acquired flat feet, there are many causes like traumatic, neuromuscular, inflammatory like rheumatoid arthritis. But what is most common is a degenerative condition of the posterior tibial tendon, which leads to insufficiency and then dysfunction and tear. That's how it progressed to an adult acquired flat feet. So I'll be talking more about, in most of the literature, the posterior tibial dysfunction and adult flat feet are used as synonyms. Now what happens, like in rotator cuff, the micro trauma over a period of time, because of the hypovascularity at this region where it takes a turn at the medial malleoli, and due to the micro trauma, the posterior tibial, which is a hammock which maintains the medial arch, gets broken, which leads to the secondary stabilizers, that is mainly the spring ligament as well as the interosseous ligament of the subtalar joint to fail. So this will lead to break in the medial arch, which all the changes are occurring at the site of talus, as well as the talonavicular joint, as well as the subtalar joint, leading to a hindfoot deformity of valgus. What happens here is the tendo Achilles also alters its direction, leading to aggravation of the deformity. Now, how a patient presents? Usually, female gender are more prone, 40 to 60, obese, hypertensive, diabetic are the commonest. We present with the symptoms over the medial side. This is a pointing sign which they show when a question is asked where it hurts the most. As the disease progress, because patient may come at any stage of the disease, the medial pain starts reducing and slowly the lateral pain starts becoming more. This is because of the lateral impingement. Now, the first and foremost thing is the footwear examination. It will tell the story what the patient is having, what deformity patient is having because of the wear and tear. Now, patient need to be examined 360 degrees, from front for a pronation deformity, from back for a valgus, from the side for the drop in the medial arch, and from the top for the posterior tibial or the ankle swelling. Now, there are few pathognomonic signs. One among them is a too many toes sign. So, normally what happens on the left side is a condition where minimum of 2 toes can be seen. But if there is more than 3 toes can be seen, then it is called as too many toe sign. What it indicates is the foot is drifting away from the midline. That is a abduction of the foot. So pronation or supination and abduction. But this can be misinterpreted if the axis of the knee and hip is not kept properly. In this position, in this patient, where it can be sign can be false positive because of the rotation at the or deformity at the knee. Of late, this too many toes sign is not a specific sign to tell, but it is one of the signs. The double heel raise test, as already spoken, this is a normal double heel raise, how it appears. Usually in a case of this patient has presented with the pain in the left ankle. Now on raising both the heel were pointing towards the midline. That is a normal. Now this patient, just try to play the video.
It is coming when you click onto the picture on the last side. It is coming.
I don't think so, sir. 1 minute. Okay. Now in this patient, the previous test is a double heel raise test, where both the feet are into valgus. In the second patient, it is the fixed deformity. This is diagnosis whether the foot is fixed or whether it is flexible. The second important test is a single heel raise test. Normally, patient can raise the heel on a single heel for around 5 to 10 seconds. In a case of single heel raise test, just let me just check once. I'll unshare and share it again.
Dr. Krishna, if you move the cursor onto that image on the right side, just move your cursor there.
Yeah, I have 1 minute, sir. One minute, sir, because my cursor stopped moving. I'm sorry. Okay, it's fine. On palpation, now if you palpate the medial ankle, along the medial ankle, around the posterior tibial tendon, if there is tenderness, that is one of the signs. Now on palpation, there are certain maneuvers are important, very important, because as I told, pathomechanically, the direction of the Achilles is changed. So ruling out Achilles tightness or a gastroc tightness becomes very, very important in order to get the things right, because one of the main complication is Achilles tightness. And second thing is the correctability of the heel valgus. So this is again one of the signs to tell whether it's a flexible flat feet or a rigid flat feet. Now, checking for the motor power. Again, it's a tricky situation actually because of the tightness of the peroneal. You may not find all the time the tightness being or the power of the tibialis posterior being checked thoroughly. There are finally, when the examination is done, there are a few things we need to look at which are crucial. First is whether patient has an asymmetry of the flat feet. Patient may come with the flat feet on bilateral side. One may be progressive, another may be a not so bad or not so deformed. Whether with the history as well as with the clinical examination, the worsening of the flat feet is also an important point during the examination. And of course, the flexibility of the passively correctable feet is also an important aspect while deciding the treatment. Now, clinically, we need to stage the posterior tibial dysfunction or a flat feet in an adult feet in order to determine what kind of treatment patient needs to go. In a patient where there is no deformity, it's or patient may present with a flexible deformity, where in a double heel raise test, both the heel are pointing towards the midline. And in the stage 3, where it is fixed, both the heels are looking outwards, it's a fixed deformity. Or in a stage 4, where the valgus is at the ankle. So these are the 4 grades of clinical staging of the adult flat feet. Now, Deland et al. Has modified this grading of these 4. Only the second grade, where the flexibility of the foot is again being modified, is very important from the point of view of treatment into a moderate flexible deformity or a severe flexible deformity. This is depending on the radiology also, because the, in stage 2A, that is the talar uncoverage, which is less than 30%, is called as stage 2A, and more than 30% is known as stage 2B. So what it requires is a thorough clinical examination to know whether it's a flexible flat feet or a rigid flat feet, corroborating with the radiographs, which should be bilateral and which should be weight bearing. Of course, a sonologist trained in musculoskeletal sonology can give a good perspective with an ultrasonography because it's a dynamic study, and MRI is needed to rule out other problems. Nowadays, weight-bearing CT is becoming more popular because we can predetermine the amount of deformity as well as post-operatively we can assess the correction which we achieved. Now, weight-bearing radiographs, how bilateral is important. Now, in this patient, it's a ankle valgus which is seen. It's a grade 4 where you can almost see deformity valgus with the arthritis and the stress fracture occurring at the fibula on the right side compared to left side. The hind foot angle or a Saltzman's angle, Saltzman's view, which is giving a hind foot angle, is an important tool nowadays to get a assessment of the hind foot alignment as well as to get a correction which is desirable. Of course, in AP view, we record the height of the ankle comparing on both sides. And of course, the calcaneal pitch angle, which is, you can see here, both the sides it is affected, but on the right side, it is even the ankle joint is affected. And the second important finding is the Meary's angle or the thallus first metatarsal angle, which is reversed. Up to 4 degrees normal. It's on one side it's 10 and other side it's 7. So weight-bearing X-rays are utmost important, corroborated with ultrasonography because of its dynamic nature. We can almost predict the amount of tendinopathy or a tear with a good musculoskeletal radiologist. And this paper told that ultrasonography, which is a reliable tool for the diagnosis. Of course, MRI is helpful when these adult acquired flat foot are along with other problems like a spring ligament tear or a tendinopathy or with some other problems like tarsal tunnel syndrome. Now, management conservative is aimed at eliminating the clinical symptoms, prevent the progression, as well as improve the hind foot alignment. These are the goals of conservative treatment. Now, how we decide this, it depends on the pathology. On a broad way, in stage 1 and stage 2A, where the deformity is flexible, it is the education, unloading, reloading, and prevention. That is mainly the physiotherapy with orthosis will help in stage 1 and 2A, where the deformity is flexible. In stage 2B, where it is the flexible deformity with severe deformity, reconstructions are needed. And in stage 3 and 4, it is fusion over the reconstruction. So these are the few clinical case examples. This lady presented with a 60-year-old lady was brought, one nurse, mother was brought. She was 60-year-old doing all her job, suddenly came with pain in the left ankle. Now you can see both the ankles were having a deformity, but left ankle patient was having pain. Now a double raise test was possible, but the single heel raise test was negative. Very difficult to get the heel raise. Very difficult. With the pain, patient was not able to lift. So we investigated with the weight-bearing X-rays, which obviously showed both the calcaneal pitch angles were decreased and the Meary's angles were reversed, and the hind foot angle was also is abnormal. Now we got an ultrasound which showed a tenosynovitis with a partial tear. So a conservative treatment in this patient initially in a step ladder fashion was given with an anti-inflammatory with a splint. In this, a controlled ankle motion boot was used here and ice packs were given. And 3 weeks down the line, the same lady was able to do double heel raise as well as the single heel raise was also possible on the left side. So bracing initially, then the orthosis. Once the patient goes or improves from the acute stage, then the exercise regime, and then followed with the exercises, range of motion first, and strengthening and stretching are important. There is a stage 2, there is an example where the 41-year-old hotelier had to leave his job because of a road traffic accident, which he injured his right side with an avian and calcaneal fracture, avian of the talus and calcaneal fracture. He came with a left ankle pain, which was very disabling for his day-to-day work because he has to stand for a long time. On examination, it was flexible deformity on the left side, and patient could raise on single toe as well. So in this patient, when we assessed with the radiological features, there was a calcaneal pitch angle as well as Meary's angle, and there was a midfoot drop at the cuneiform. But the deformity was, the uncoverage of the talus was not much. So this made us think about giving him a conservative trial. Now for the already injured right side, we gave a double upright brace. For a left side, which was symptomatic, we first gave a custom-made orthosis, which was taken according to his foot shape, and it was put into his footwear, and he was judiciously using this, followed by a muscle strengthening with a TheraBand. And in 3 months follow-up, patient was absolutely pain-free, and he was very grateful actually. This is a case example for rigid deformity. Now this patient is a 13-year-old boy. Mother came with an anxious mother came with a patient having severe pain. So this patient presented even with an C sign and the X-ray. Patient's only left side was problematic, right side was problematic. Even both the feet showed rigid flat feet. We thought a trial of conservative management will give, because even though the conservative treatment works best in stage 1 and 2, all stages should be given a fair trial of conservative management according to the literature. So we gave with an anti-inflammatory and cam walker on presentation, followed by a medial arch support was given, and then with an exercise regime. In the COVID time, patient mother called and patient is very happy and doing well. Now it is almost 2 years down the line. So conservative management has got a role even in case of rigid. And this is the last case where stage 4, where there is a deformity at ankle, where it's a rigid feet, where all the parameters are deranged. As well, there is an ankle joint which is arthritic. We radiologically evaluated this patient and gave a trial of, because patient was not opting for even for an MRI. So, and for the surgical options, we gave a trial of a boot in this 60-year-old lady. She was tolerating it well, but after this double upright brace was given, she was quite happy avoiding, and she was happy avoiding the surgery. So braces to orthosis, rest to exercise is what improves the gait, relieves the pain, and prevents and delays the arthrosis. Now coming to rationale of this, in flexible foot, we mold the orthosis so that it controls the progression. In rigid, we support the foot so that it immobilizes the rear foot. That is a concept of conservative. This one article where this non-surgical treatment was studied for 7 to 10 years, longest follow-up. There was a prevention of clinical progression of the disease to advanced stages. And more importantly, the chance of being brace-free and avoiding surgery was 69%. This was our Indian population wants. They are not very amicable for the surgical management. So this one paper I could find in 2020, which was published, what is right in flat foot, right from what is appropriate in flat foot. Obesity, BMI in adults, it definitely contributes. Equinus deformity in the rear feet is definitely appropriate, and spring ligament tear is appropriate. What is not so appropriate is a single heel raise being a pathognomonic sign, and intrinsic valgus, and even orthosis helping the patient to symptomatically relieve, as well as foot orthosis and eccentric exercises alone reducing the symptoms are not so appropriate. Now, finally, this is a systematic review which was published in 2020. The important thing here is only there are 4 randomized controlled trials are there in the whole systematic study which was done up to 2020 from inception, and 3 different types of conservative treatment was used. So in conclusion, they concluded by saying that there are further studies required to recommend a conservative protocol, but they observed that foot orthosis and exercises are better tolerated by the patients, and custom-made personalized orthosis are very well accepted by the patients. So this is a small pilot study we did, 40 patients of adult patients. Our aim was to functionally evaluate with a prefabricated and a cost-effective custom-made. So custom-made orthosis was made in our artificial limb center, and it was put on the patients. In the prefabricated, we could see in 6 months' time an improvement in the VAS score of 4 from 7, and AOFA score improved from 48 to 79. In 6 months, the deformity didn't progress. So in summary, conservative treatment is a viable option, definitely in early stages, even though it is recommended in all the stages. Compliance to braces is a challenge in Indian population because they are barefooted inside the house. So making the patient wear these braces and orthosis is a challenge. And lack of long-term RCTs are not available. So conservative protocol, we can't tell that this is a way to go about. And conservative management protocol in Indian population is a need of the day. Thank you.
Thank you, Dr. Krishna. That was a comprehensive talk with regard to even telling us about the AFD as well as
Yes.
about the acquired flat foot as well as its conservative treatment. I think are there from the panel, are there any questions, sir? Any questions which have come in, Dr. Mali?
No questions from the panel.
Okay. And Dr. Prakash, I think he had some connectivity issues, so he's just mentioned that. And so can we plan with the further talks, or can we just have some case discussions now?
It's your wish, sir. What about you?
Yeah, okay. Yeah. Dr. Graham, any cases that you would have now? Either you or Dr. Lucas have some?
Yeah, I think I definitely have a case, but I would like to reserve this case until after I give my talk, because it'll put things into kind of more context. Yeah, and I definitely have some other comments too, but again, I want to reserve those until after I give my presentation. So
okay, I think Dr. Lucas had he's raised his hand. I think yes, Dr. Lucas.
I'm here. Yeah.
Yes, sir.
Because my presentation, I thank you, Dr. Krishna, because I'm amazed how great your presentation was, and all of the presentations are great here. Really, I would like to have them, all of them, for my students, for my doctors, and they're brilliant presentation. And if you want me, so in my presentation, I have created an algorithm about surgical adult flat foot treatment. So if you want me, so I can share that algorithm with you. Yeah.
I think maybe we should do it this way. We'll continue with the talks. We'll have Dr. Lucas speaking about the adult acquired flat foot, followed by Dr. Graham about his talk on the EOTTS, and then we have the case discussions all at one go. Would that be good?
Yeah, great.
Yeah. Okay. So can we have Dr. Lucas then, please?
So can you see my screen? Am I
Yes, we
sharing?
can.
Yes. So
Yes, we can.
thanks to Dr. Krishna. So here we have rigid flat foot. We don't want patients in stage like that. But that exact patient came to my office for hip surgery because of hip pain, because of hip arthritis. People get used to foot pain. They like to massage their foot, soak them, use some foot insoles, and but other joints are hurting them also. So when all this biomechanical chain is disturbed and distorted, so they have also pain in other joints, not only in foot joints. So I will not bother you with all these too many toes and single heel rise tests because Dr. Krishna described them brilliantly. So I won't bother you. We don't know what is the etiology of adult acquired flat foot. We don't know. It's a bone problem, ligamentous problem, or maybe problem somewhere in our mind, in our software, in our head, or maybe some hardware. We don't know. We know all these symptoms that foot are flat. We have heel valgus. We have pain on the medial side, and then we have pain on the lateral side. It's obvious. We know that we meet these patients everywhere around us. They are overwhelming. It's a very big problem, especially in my society. It's a big problem, and I think maybe in our society I think it's connected with obesity. We have a lot of obese people in Poland or in Europe. We don't know what was the what's the attacker or who is the victim, or tibialis posterior was the first or was the victim of bad alignment. Uh, Dr. Krishna described us all these stages from 1 to 3rd stage according to Johnson, and also with 3rd stage, which was added by Mike Meyerson. We have also other staging system, very complicated Blauman staging system, and also MRI staging system. Although MRI is not standing examinations, but you lie down to you lie flat to do foot MRI, but Conti has prepared MRI staging. Of course, spring leg is quite often involved. You can see on the left picture a big hole in a spring leg, and sometimes in later stages deltoid is also ruptured. We know all these silver scale tests. If we have present still present tibialis posterior, we can do some side to side attachment to but any other and repair. But I have created an algorithm for painful flat foot. When you have painful, of course, when no pain, so maybe no treatment. So pain should force us to treat people. This is classical algorithm, and I have, according to knowledge which partially I gained from Michael Graham, I created my own modifying, my own algorithm, which is very, very subjective. So everything what I'm going to tell is extremely subjective and based mostly on my own experience. So I'm sorry for that. It won't be supported by by any papers. So first, in algorithm, we have to decide if the foot is still corrective or it's rigid. If it's corrective, so in my hand, and patient is cooperative and it's quite young and foot is still flexible. So in my hands is usually AOTTS or hyperocura, which is called here HPC. If it's okay, I just leave it like that, nothing else. So way to that moment is very short. Sometimes it's still not okay. Sometimes correction is not adequate. Patients want more, or in some cases we don't achieve enough correction. But AOTTS does not close doors to other procedures. And then my favorite procedure is calcaneal osteotomy, MDCO, sometimes connected with cotton osteotomy. Very rarely, really, maybe 5 to 10 times a year, I do LCL, lateral column lengthening, mostly Evans, because we have very fancy implants for Evans, which are quite helpful. I rarely do, maybe I did 20 in my career. I rarely do calcaneocuboid fusion with bone graft. Of course, when we have stage 3 or stage 4 rigid flat foot, we have to decide whether we do only selective fusion of mostly affected and painful joint, or we do classical queen of foot surgery. We do triple or modified triple, in other ways, double fusion. Of course, in the middle of my algorithm, there is always decision what to do with heel cord contracture. Of course, we have to decide we are going to work only to do vulpius or strier, or maybe triple hemisection, or maybe normal tendo-Achilles lengthening. But as you see in that presented algorithm, heel cord is quite far away from my quickest and perfect way from corrective flexible flat foot to AOTTS or hyperocure in implantation. So I rarely do this procedure in one setting, and I rarely touch heel cord. Of course, I always take under consideration age of the patients, obesity, cooperation, if patient is able to understand what I say. Because in my opinion, soft tissue surgery is not enough when we have bony deformities. Here is the example of classical adult flatfoot lady. She is in her 50s. She has a lot of pain in her foot, in her thigh, in her spine. She's, of course, like every person, she's afraid of surgery. She is afraid of cast. She is afraid of crutches. She's afraid of immobilization, and she's not very keen to undergo surgery. So, of course, we have to discuss with everything with her, but I don't believe that the conservative option is helpful. What helps me to decide whether do Evans or calcaneal osteotomy? So when deformity is mostly in frontal plane, so it leads me when the forefoot or when the foot abduction is the biggest deformity, it pushes me into Evans calcaneal osteotomy. But when flat foot compensation is mostly in heel valgus, so my way is to do MDCO, medial displacement calcaneal osteotomy. Dr. Krishna has already told all about Achilles tendon or heel cord vector. So MDCO works like on that picture. And here is an clinical example of calcaneal MDCO and tibialis flexor digitorum longus transfer into the navicular. And when we have mostly frontal plane deformity, so Evans calcaneal osteotomy is probably no, for me, in my hands, it's a better option, especially that nowadays we have quite nice and sophisticated implants which helps us to complete Evans osteotomy. Evans osteotomy is placed somewhere 1 centimeters behind the calcaneocuboid joint. And here is a radiological example after four years of that procedure. Of course, it's not always successful. It can increase strain in CC joint and cause chronic pain in CC joint, and sometimes non-union. Sometimes we can damage subtalar joint, so it's not benign procedure. And here is comparison of calcaneal osteotomy, which is not the true correction, versus TTS, which is really true correction, true biomechanical correction. We can see it on that scheme. So it's we can correct heel cord axis and hindfoot axis with calcaneal osteotomy, but we can do it much better with correcting in situ with EOTTS problem. And that gives, that in my hand, it gives really triplanar correction of the deformity, not like a kind of false correction. We create new deformities with MDCO or Evans. We just create new deformities to correct previous existing deformity. You know all these pictures, so I won't bother you anymore. And here is some clinical examples of very nice correction of the flat foot in frontal and sagittal views, and even in older patients, it's possible. Subtalar arthroeresis, it's not a new invention. It's quite old, but it has a lot of bad results. So that new Michael Graham, and is not new, but well-established Michael Graham device changes everything. Some technical points in doing calcaneal osteotomies in my hands. So this is how I do it, how I do the osteotomy. Some biomechanics behind it. I usually do calcaneal osteotomy while patient is lying on the side. I don't like other positions. And here is the most dangerous part, to avoid sural nerve damage, because patients are complaining, especially when they have painful neuroma of the. It's nice to have sural nerve visible like that, which is very helpful. And sometimes we are not able to find, sometimes I'm not able to find the sural nerve, so I do very careful blind dissection of the tissues covering calcaneus, and here how I put two small Haumann retractors. I know a lot of people now doing it percutaneously with minimally invasive burrs, or but really incision is not big one, and it's nice to have everything visible. I always put my hand on the medial aspect, not to break the lateral medial cortex with a saw. I finished my work with an osteotomy like it should be, and then we have to mobilize osteotomy site. It must be mobile like that. It must be mobile like that in order to have good correction, and then stabilization with screws. We can use any big screws, 5 to 7.5 screws, which can hold that piece before hammerplasty. Piece of bone can be very useful, especially when we do further procedure on the medial side. For example, when we want to transfer flexor digitorum longus on the navicular, so I usually put that bone chips into the tunnel, and then we have to do hammerplasty of that sharp lateral edge. There are also other osteotomies which I'm not very familiar, so that's why it's only the scheme. Probably it's like something like a scarf osteotomy of the calcaneus. I'm not familiar with that osteotomy. And here is LCL, which we can do like an Evans osteotomy, just 10 millimeters behind CC joint, and Hintermann osteotomy, which goes through the sinus tarsi, or we can lengthening lateral column in cases of mostly abduction deformity. We can correct it with calcaneocuboid destruction, arthrodesis destruction fusion, but we need some kind of bone graft from iliac crest, or sometimes maybe in younger person with artificial. And here is the approach. Here is the approach for LCL in my hands. So usually I use the cast 4 to 6 weeks after surgery, non-weight bearing, and after a month, or in all more osteoporotic patients, after month and a half, I allow them to weight bear fully. And now the queen of foot surgery, which is triple arthrodesis, triple fusion, and in and triple fusion now sometimes it's called in the papers modified triple fusion, which is double, like calcaneo, talocalcanel and talonavicular fusion, just double fusion, which is much easier. In a flat foot, I do that double fusion from entirely medial approach, because deformity and soft tissues are hurt on the medial side. So I usually go from medial to lateral, not from lateral, and it looks like that. I'm using compressive staple because I'm not a qualified foot and ankle surgeon, and I'm fighting a lot implanting screws through that joint, so I preferred compressive staples. In Meyerson grade 4 deformities, horrible deformities with stress fractures, I usually do hindfoot fusion, and look how hindfoot nail corrects all midfoot deformities in one surgery. So thank you for inviting me here. I'm trying always to create a team. So when I'm working, when I'm concentrating on work, always I want always a friend of mine to watch me if I'm doing it correctly. Thank you very much.
Thank you, Dr. Lucas. Thank you so much for that presentation on the surgical aspects of the adult acquired flat foot. Can we have any questions now, or are there any from the panelists?
Any questions?
No questions. Let us move on to the next talk.
Vamshi, no questions?
Okay. If there aren't any, then
Dr. Vamshi?
No audience questions.
No audience questions?
okay. There aren't any, then we'll would like to invite Dr. Michael Graham to tell us about the EOTTS and also about the pes planus in general. Dr. Graham, over to you, please.
Okay, that's great. Thank you so much. And it's a pleasure to be here. And I want to thank all of the other presenters, and great presentation. Let me just see. I want to make sure my videos are working. Yeah. There we go. Okay, so this is a very controversial, or potentially controversial, I don't really know why, procedure with the use of a sinus tarsi implant. And as you know, there's a lot of different terminology that is used to describe this procedure. And historically, it was arthroeresis, which is a joint blocking or joint limiting procedure. And we don't really want to limit a motion, especially subtalar joint or talotarsal joint motion. We want to restore the motion. We still want to have a normal amount. And so when I was looking at the deformity, and we're going to get into this a little bit, I said, you know, we don't want to call this procedure with hypercure the same as the other arthroeresis devices that don't really have a great long-term track record. And so again, I want to thank everyone for the invitation for this. And Dr. Joy had even kind of was saying, you know, is this a novel treatment or a game changer? So I really like that. And hopefully, you know, I'll just open everybody's eyes if there's still some skepticism about this. And I want to say right off the bat that there is not one treatment that works for every single patient. With foot and ankle surgery, we're dealing with so many different components that we have to not just have tunnel vision and look at one part of the foot. We have to take the entire foot structure into consideration. And that's why we have to have these algorithms like Dr. Lucas has just shown us, so that we can put all of the pieces of the puzzle together. Because ultimately, when patients come to you with whatever concern, we want to have an option that makes sense for that individual patient and really for each foot. So I want to talk about, you know, the EOTS procedure. Is this something that you can trust for your patients? So at the end, you have to be the judge of that. Ultimately, what is our goal? It's to enhance the quality of life of our patients so that they can go out and just simply walk, exercise, and to try to improve their quality of life. When you have chronic foot pain, this affects you in so many different ways, because it limits your ability to just go out and do one of the most common conscious functions of our body, and that's just simply to walk. And, you know, one of the things that they did to us back in school is we had to put a stone in our shoe, and then we had to walk around the whole day with this stone in there, so that it would mimic what our patients are sometimes going through and how painful this can be. And so again, we want to have great options for them to reverse that. Now, as you know, we've learned from Dr. Prasad and also with Dr. Lucas is, you know, kind of the controversy surrounding what exactly creates a misaligned, lower than normal arch foot structure. And, the debate kind of keeps always going around. Is it a faulty spring ligament? Is that what collapsed and then led to this whole hindfoot misalignment? Or is it posterior tib dysfunction, insufficiency, whatever you want to call it, that it's the tendon that wore out, and then now the talus is collapsing and becoming misaligned because of that? Or is it an equinus, a tight Achilles tendon, that leads to this deformity? But to me, those were all secondary to the primary condition of a partially displacing, subluxation. There's a lot of different terms that we can call this, talus, because the only difference between this normal aligned foot and this flexible flat foot, if we want to call it that, is when the talus is aligned on the calcaneus, or when the talus is partially dislocating and causing the obliteration of the sinus tarsi, the navicular drops, and then that is going to increase the strain on the posterior tibial tendon. Now, this child here with their posterior tibial tendon is completely healthy. If we took a MRI, or if we opened up the patient's foot and looked at the tendon, it's healthy. But then if you fast forward 50 years after the patient has taken 80 million steps, I'm sure that we're going to see pathologic changes to that tendon. So, we always say that these pediatric flat feet, that they're a normal variant. And there's even literature that says that, there's just no reason to give any kind of treatment to this pathologic deformity. I mean, this is not normal. And so we have to really change our mindset, and we have to think about this as a disease process. Just like hypertension and diabetes, early on, you don't have any symptoms with those diseases, but yet we still implement a treatment to try to lower the blood pressure, lower the blood sugar. Well, walking is the most common function of our body. So every step that we take, we're leading to more and more pathology within our feet, and then also to the knees, hips, and back. So there's absolutely no evidence that conservative care can stabilize and maintain the alignment of the talus on the calcaneus and revert all of these pathologic secondary changes that are going to occur. Now, conservative care can help some, and we're happy about that. But at the end of the day, one of the major issues with conservative care is patient compliance, because especially in India, we can't force patients to wear shoes all the time while you're in your house. And just even there's a limitation of what kind of shoe people are going to be wearing, or to say, unfortunately, to a child, you're going to have to wear this big bulky brace for the rest of your life that has such a negative psychological impact as well. So again, we have to really think about what we're telling our patients and what kind of treatments we're giving them. Is this actually fixing the problem or not? This condition will never autocorrect. And that is one of the biggest travesties that's out there, is this myth that children outgrow a flat, flexible, flat foot. Now, yes, we know that they have a fat foot, but when your talus is partially dislocating on the calcaneus like this, there is no evidence whatsoever, not one single case study, that shows that 3 or 4 years later, that all of a sudden the talus is now aligned on the calcaneus, the sinus tarsi remains open, and life is good. There's no cases with that. And what we do see from, again, Lucas's study and from Krishna's study is that these feet get progressively worse. So every single step that's taken, we have excessive forces acting on the soft tissues and the joints within the foot and ankle. And then we have the secondary deformities that occur because of that, secondary to Wolf's and Davis's tissue reactive loss. So our goal with treatments, and not everybody is, this is not a life and death situation, so we don't have to rush patients off for surgery, but our goal is to offer a minimally invasive internal option that's reversible, does no harm, and has been proven to be safe and effective. So that's what led to the development of a sinus tarsi stent. And so historically speaking, this design, this implant has been used since 2004 in both pediatric and adult patients. The youngest is 3, the oldest is 94. And I'm not saying that this should be used in every 3 or 4-year-old patient. Again, that comes into your clinic, but I'm just saying that this has been used in individuals that young and old. There's tens of thousands of these devices that have been placed all around the world. This is not something where we only have a few hundred cases. And it's approved for use in more than 60 countries around the world. And it's trusted by foot and ankle surgeons also. So I want to talk about the good and the bad and the ugly with this procedure. This is not a commercial about this product, but this is about this solution. So when the talus is balanced on the calcaneus, the majority of the weight-bearing forces are supposed to pass and act on the posterior talocalcaneal facet. And only 48% is supposed to go anteriorly. But what happens when there's a partial dislocation, subluxation, whatever you want to call it, those weight-bearing forces are now shifted from posteriorly to anteromedially. Okay, and so again, this is the force, this is that negative energy that stretches the spring ligament and causes atrophy of the ligament. So if you stretch any soft tissue for a long time, of course, it's going to eventually wear out. And when the spring ligament wears out, then that's going to increase the force on the plantar fascia. So with all of those patients that have chronic heel pain, the plantar fasciitis, what is the number one etiology of plantar fasciitis? It's because of overstretching of the medial band of the plantar fascia. Why does that overstretching occur? It always, you will see, and there's been a paper published on this, that about 95% of patients with plantar fasciopathy have a partially dislocated talus. And then the same is true for the posterior tibial tendon. Whenever you look back at any of the x-rays of your patients who have posterior tib dysfunction, they always have a misaligned talus. So with the Hypercure stent, once we place it into the sinus tarsi, so this is extra osseous, so we don't cut into the bone whatsoever, it's extra articular, the stent does not go into cartilage, so this does not cause arthritic changes whatsoever into the sinus tarsi space. So we're able to decrease the anteromedial forces by 24% and to rebalance the subtalar joint forces. Now, one of the things too, just even looking at this x-ray with the Hypercure stent in place, it just looks dangerous. It looks like this would cause a fracture of the talus or the calcaneus if somebody is going to walk with this in their foot. But after, again, tens of thousands of cases, we don't have a single case of a fracture of the talus or calcaneus. The reason why is because those weight-bearing forces are acting on the posterior, middle, and anterior facets. There's actually very little force acting on the stent itself. So, so that's just, again, peace of mind thing. So again, we look at this picture and just think about the forces that are acting posteriorly and anteriorly. There is going to be some force that helps to maintain the alignment and stability of the talus on the posterior dorsal aspect of the stent, and then also on the plantar distal aspect. And probably over time, if we took MRIs, yes, we would see that there would be a little bit of bone strengthening, density, increase in density, and the areas of contact between the bone and the implant. And that's just the body's way to protect itself. So what are the proven results of this? Well, number one, we're going to increase the height of the navicular. That's going to increase the arch, the medial arch of the foot. And instantly, that will decrease the strain on the posterior tibial tendon by 51%. Also, we've published a paper that shows a 33% decreased strain to the plantar fascia. So the reason why I bring up and why it's important to consider the plantar fascial strain is because so many patients that are out there that have chronic heel pain, that are eventually told what we're going to do is to go in and just either cut the plantar fascia, do a partial release, or eventually the plantar fascia just auto ruptures on its own. Well, the plantar fascia is very important to stabilize the medial column of foot bones. If we cut the plantar fascia or we lose the stability of that, then that's going to put more strain on the spring ligament and the posterior tibial tendon and lead to their destruction also. And then we have the secondary part of the altered fascial stability with the forefoot, because then the forefoot is stabilized also with the plantar fascia. So as far as what is the evidence basis for the safety and efficacy of this implant? Well, we have multiple published peer-reviewed papers in both orthopedic and podiatric journals by a wide variety of authors, again, internationally, that have shown that that this actually works and that this is should be a mainstay in your treatment toolbox. I'm not going to go spend a lot of time on this. We have a website where surgeons can go to get more information called hypercuredoctors.com. But anyway, so this is just, we can decrease the forces acting on the medial column of foot bones. Of course, we're going to stabilize the talotarsal joint while allowing a natural range of motion. So the arthroeresis devices, they smash into the implant and decrease the normal amount of motion. So we help with tarsal tunnel and increase the sensation to the bottom of patients' feet, decrease the strain to the plantar fascia posterior tib, which we already talked about. The most important part too is the survival rate, the retention rate of this implant. It has a 96% success rate when you use it in an ideal patient. And that's a very important point, is that sometimes you're going to use this in high-risk patients, and in that situation, we don't have the evidence for that, but it's going to lower the success rate because you have other parts of the foot that aren't functioning as they should be. So when we take a look at what is the worst thing that can possibly happen after all of these years of using this implant, well, the most common that we see, and not that it's that common, is implant displacement. Usually, this is not a fault of the implant itself. It's bad surgical technique, because one of the things that you have to do is to decompress the soft tissues within the sinus tarsi. If you don't decompress them, then you're not going to be able to place this stent as deep as it should go into the sinus tarsi, and then the uncut fibers of the interosseous ligament can act as a rubber band and push the implant laterally. There's varying degrees. Just because there's some stent displacement does not necessarily mean that you have to take the patient back to surgery. That's only if they've lost correction or if they're developing pain in the area around the sinus tarsi. The other part too is that the orientation of the sinus tarsi space is oblique, not lateral to medial. And this was a big design flaw with a lot of the arthroeresis devices that were simply placed from lateral to medial. And then you have the lateral process of the talus smashing onto that device 6,000 to 8,000 times a day. And so after about 2 to 3 years, most patients developed chronic pain and the implant had to be removed. So when you put in the Hypercure implant, you have to make sure that it goes obliquely and very deep. We're going to talk about that. And just like what Dr. Joy talked about also, is that you have to look for co-deformities, especially a tarsal coalition. Because if somebody has an undetected coalition and you try to place the implant, well, that could, number one, prevent you from placing it, or number two, it could compromise the results because we're not getting the normal talotarsal range of motion. Now, if you put in too small of an implant, then the implant can shift around in there and then kind of wiggle its way out. Or if you overstuff and put too large of an implant, it's not going to go in as deep as it should, and then it's going to also work its way out. So there is a little bit of a learning curve when you start performing this procedure. It takes about 10 to 15 cases before you really gain your confidence with it. Of course, there's been situations where patients were so happy and had very little pain that they were running and playing and being a little bit too overactive. And it takes about 4 to 6 weeks for the implant to really be fully seated and adhered to by the soft tissues within the sinus tarsi space before the implant will then be prevented from displacing. So if you've put in the stent and you see that it's partially displaced like this, what do? Well, one of the good parts of this option is that it is completely reversible. So in having that as an advantage is also then going to give a partial disadvantage, because if we were able to just drill this into the bone, then we wouldn't have this issue. But if we drilled it into the bone, then that could potentially create other secondary deformities. So it's not that common to have a stent displacement. Again, usually if the surgical technique is performed correctly and the patient listens to what you tell them to do, and you've addressed other coexisting deformities, this should not be that common. So if something like this happened, you just remove the implant, you take your Stevens sternotomy scissors and you recut the fibers within the sinus tarsi, retrial size to make sure that you have the correct size. You push the stent back in, and that's the end of the story. Maybe you should limit the patient's weight bearing for about 4 to 6 weeks. Usually we say no running or jogging until at least 6 to 8 weeks after placing this into somebody's foot. Displacement after 3 to 4 weeks is very rare. It's less than 1%. So, but we like to give a little bit of an extra cushion so that patients will take it easy for a longer period of time before they go back to running or jogging. Again, ruling out a tarsal coalition is extremely important, and a coalition is not a contraindication if you remove the coalition. And again, that's what Dr. Joy showed his case with removing the coalition. Because a lot of times, historically, let's say that your patient did have a coalition, a calcaneal navicular, and you just went in and you resected that. Well, a lot of times the patient has even further instability in their foot, and it leads to further complications. So now we have an internal option that we don't have to cut the bones and do major surgery, that we can still stabilize the hindfoot and restore the natural range of motion. So we have to rule that out. So when a patient presents to you with whatever complaint and you see something like this, you know, we don't know if there's a coalition there or not, and we don't want to have to just send every single patient off for expensive CTs or MRIs if we don't have to. So the first thing that you should do when you have a patient like this with a partially displaced talus is to take a second X-ray with their hindfoot, either non-weight bearing or just if they can realign their hindfoot like this one, then we can definitely rule out that there is no coalition. Now, to go back to this patient too, if this patient was in your clinic with for a consultation, what kind of a treatment would you offer them? We know that any kind of external exercises, an arch support, a brace is not going to realign and stabilize the talus on the calcaneus. And we don't want to just have to go in and do a subtalar joint fusion on a pediatric patient. So that's why now if we would have taken this second X-ray to see that the talus completely realigns on the calcaneus and we have a reopening of the sinus tarsi, now it makes sense. Why can't we just place a titanium spacer into this, the sinus tarsi to maintain the alignment and stability of the calcaneus? This is going to significantly help this patient. Now, one of the other things too is that earlier on, you're going to there's some kind of clinical judgment as far as which size do I need, even though the most common sizes of hypercure are size 7 and 6. And this doesn't matter if it's an adult patient or a pediatric patient. So those are the most common. So, you know, here's a situation where there's an undercorrection. And, you know, one of the issues with this is that we can't just place a trial sizer into the patient's foot and then have them get up and walk around. So the entire judgment of the size of this implant is when the patient's on the operating room table. Now, I have the red arrows here, which is the bisection of the talus. The bisection should be within the first metatarsal or over into the first intermetatarsal space. So anywhere when the bisection is in that space, then we have a perfectly aligned talus. Anytime the bisection is medial to the medial aspect of the first metatarsal, then we have a transverse plane deformity. So this isn't the end of the world. We don't have to amputate the patient's feet or do something crazy. All we need to do is to remove this slightly smaller size and then use a slightly larger size, and we'll be able to get more correction. Now, with some patients, they have such a severe deformity that you're going to have multiple forms of correction. So you can always perform a hypercure along with a lateral column lengthening. And you can perform the, not that we want to, but sometimes it's questionable where we have to do it as a stage procedure. We can tell the patient we're going to try to put in hypercure, and then if we need to add more correction, then we can do a lateral column lengthening. Other times it's clear cut. This is such a severe deformity that we have to do a combination of procedures at the same surgical setting. So the removal of this device, and this is in an adult patient, is you twist the implant 360 degrees. This breaks up the adhesion, and you can remove it. Now, why would we have to remove the implant? Well, either if it's an over or under correction. Some patients have chronic just pain to their subtalar or to the sinus tarsi area. A lot of times those patients have had chronic ankle sprains, so the ligaments just aren't as adaptable to the new hindfoot alignment procedure. So we always want to recommend giving maybe 1 or 2 steroid injections into the sinus tarsi space or into the lateral ankle ligaments to help facilitate the ligament adaptation. But every once in a while, you just have a patient that they just can't tolerate it. Usually you want to give it about a year before you end up removing the implant. A lot of times, initially, the correction will maintain because the ligaments have tightened, the tendons have also strengthened because they have not had that chronic stretch on them. And then there's also scar tissue that could build up within the sinus tarsi space. But my observations have been that usually there's a long-term loss of correction. So we have to make sure to address other coexisting deformities, like if the patient had a metaductus. So the surgeon in this case, for whatever reason, said, let's just put in a smaller hypercure. We don't have exactly the correction that we want, but the patient only wanted to proceed with that versus having a forefoot surgery as well. And so just as long as the patient is happy, then we're happy. So, and we have internal correction, something, again, better than an external device. Now, the ugly of this case is when we have poor patient selection. So in the upper X-ray here, we see that the talus is not aligned, but we also have coexisting significant pathologies that are not going to autocorrect. So we have a negative calcaneal inclination angle. So we could put a hypercure in, but we still have a significant hindfoot deformity. So we have to perform a TAL and maybe a medial displacement calcaneal osteotomy. And then also we can use orthotics post hypercure placement too. Here's an adult patient as well. We have just a negative calcaneal or lower than normal calcaneal inclination angle. This patient needed a midfoot procedure and a plantar flexory first metatarsal osteotomy to really bring the whole foot back into alignment. So if you only put in a hypercure in this situation, it's not going to solve the problem because of coexisting pathologies. So we have to look at that. So this is such a great, it's a fun procedure. So this is a patient who, a pediatric patient who has usually we recommend having 1 foot at a time. I know a lot of international doctors like to do both feet at the same time. When you put hypercure in both feet at the same time, it's going to have a longer recovery. And potentially the patient's going to walk supinated during the early initial healing, and that could lead to slight displacement of one of the implants. So we like to do 1 foot and then a few weeks later the other foot. It's fine to do both feet at the same time. You just have to be aware that the patients are going to have a potentially longer recovery, and then there's an increased chance that you're going to have to bring the patient back to replace one of the implants. I don't have any kind of statistics on that, and that would be a good paper for research in the future. But the great news with this is the results are absolutely instantaneous. Again, we don't have to worry about the patient wearing a brace or inserts in their shoe. And again, after a few weeks, they can run, play, jump, they can perform whatever sport they want to. Long-term expectations with this procedure is that it really should stay in the sinus tarsi space unless there's some kind of an issue. Again, 3 years to 94 years. And a question that always gets asked is, what happened when you put this into a pediatric patient, even if they're 10, 12 years old, and now they become 18 years old? Are you going to have to remove that implant and put in a smaller or larger device? Well, if you've put in already the size 6 or 7 implant, that is the most common adult size. So it's unlikely that we're going to have to replace the stent once the child becomes osseously mature. Again, afterward, we have patients who are with all kinds of sporting exercises, MMA fighters, basketball players, and one of the questions that's been asked twice is the relationship between a flexible flat foot and obesity. And maybe I'm the guy with the hammer, and everywhere I look, I see a nail that I want to use my implant. But one of the things that I've noticed that has happened with patients after putting in the Hypercure is that they were able to go out and exercise, increase their metabolism, and lose weight. So what happens to those poor children who have this condition and they go out and try to exercise and they suffer as a result of that? So the last thing they want to do is to go out and run or play or to be active. So they're less active, their metabolism decreases, and then they gain weight. And so for obesity, diabetes, and hypertension, the #1 recommendation for patients is to go out and exercise. But how can you go out and exercise if you suffer afterward? So for me, again, I think that there's definitely a role of flat feet. So again, when that person comes in, there's absolutely no evidence that a device placed on the bottom of your foot can realign and stabilize the talus on the calcaneus. Now, I'm a big fan of arch supports and orthotics. I think if you wear shoes, you should have some kind of insert in your shoe, but we have to be realistic about the correction. And again, there's absolutely not a single case study that shows how that talus is realigned and there's an open sinus tarsi with somebody stepping on their custom-made arch support. And we shouldn't have to just have this as our only other option to go in and create so much destruction just to realign the talus on the calcaneus. So that's why this option hopefully makes sense, that when indicated, again, this isn't for every single patient. So I want to be very clear about that. But when it's indicated, boy, it's just a fun procedure. Everybody talks about prevention of this foot and ankle pathology. We have to prevent it, but little action is actually done. So the only way that we're going to have a prevention is with an early intervention. So, when we look at this pediatric patient, and there's absolutely no way that we can ever think that this foot will become normal. We know that this patient is doomed. Their foot is going to end up looking like this, because of all of the secondary forces that have been acting on it for 70, 80 million steps. So that's why can't we offer a minimally invasive, completely reversible option that has a long history of usage, many published papers, versus waiting until we have to go in and do a subtalar or triple fusion. And then the patient has all of the other lifelong effects because of that. So for me, I think that this really has been a game changer when you select the right patient, address coexisting deformities, and you have to affix both feet. Many times when we look at when Hypercure has to be removed, the surgeon only put it in one foot. They left the other foot untreated, And what can happen with that is just think about your car. If you have worn out tires, 4 tires are all worn out, and you've only put 2 new tires on one side of the car, but you leave the other side with worn out tires, guess what's going to happen to the new tires? They're going to also get worn out very quickly. So we need to make sure that we address both feet. So that's my quick presentation for that. And I don't know if we want to take some questions now, or if you want me to just jump into the other case study that I had.
I think maybe we could start with the case study that you have.
Okay. So I was trying to think about a case study for this. And again, usually this is about flat feet, but this condition that we're talking about is much greater than just flat feet, because a lot of people that have a partially displaced talus, they have what appears to be almost a normal aligned, or they have a arch to their foot. So that's why I don't like to call Hypercure like a flat foot solution. It's a solution for what I returned. It's recurrent talotarsal joint displacement, or RTTJD. And so one of the most common reasons why patients come in for consultation is for a bunion deformity. So we know that the #1 etiology for hallux valgus and metatarsus primus varus is because of hyperpronation. So what we have is an unlocking and an instability at the first ray, at the first metatarsal medial cuneiform joint. And then we have the excessive pathologic pressures that are acting on the first metatarsal bone, pushing it dorsal medially. And because of the force acting on the head of the metatarsal bone, then the hallux goes into a valgus. Then you have to think about the 6 tendons that are attached to the hallux, that when we're walking, they're pulling from the hallux a distal to proximal force. So that's why hallux abductor valgus and metatarsus primus varus is a progressive joint deformity. So we're looking at this X-ray here and saying, okay, well, what's wrong with this? Well, what's wrong is that the patient had surgery, but she's still complaining of exactly the same pain in her first MPJ. Now, yes, okay, one of the drawbacks of performing a Lapidus procedure is shortening of the first metatarsal head, so she could have issues under there, but this patient actually did not. The pain was in her first MPJ. So we have to say, well, what are we going to do for this patient? Well, #1, we're going to have to say, well, and this is what drives me crazy, is because everybody, they cut off the X-ray of the midfoot back. So the hindfoot is gone, and they only show X-rays of the first ray. And you should not have tunnel vision when addressing any kind of foot and ankle pathology, because there's an interconnectedness between the hindfoot and the forefoot. So what do we see, especially from viewing my last presentation, is that this patient has a partially dislocating talus. So you have to think about this as a dynamic deformity. This is not static. So when the patient has no weight on their foot, the talus is aligned and where it's supposed to be. And when they step down, then the talus pushes anteromedially, and then that forces all of this pressure onto the first metatarsal bone. So let's take a look at the lateral. So now again, usually we're only going to be looking at the first metatarsal bone, but the first place that you should really look at for your patients with a foot and ankle pathology is the alignment and position of the talus on the calcaneus. So instantly we see that there is an anteriorly deviated cyma. The reason why the talus has dropped forward is because, again, of this partial displacement, and we have obliteration of the sinus tarsi. Okay, we have a drop navicular bone. So the surgeon did a phenomenal job with the initial surgery, but we still have a hindfoot pathology that is now contributing to forefoot pain. So that's why the hindfoot controls the forefoot. So what are you going to do for this patient? Are you going to just say, well, just wear the support in your foot, or we're going to give you a brace, or maybe we'll do a subtalar fusion? Well, not so fast. So what you're going to do whenever you see a patient that has a partially displaced talus is you're going to order a second X-ray with the patient standing in neutral position. so we can see this, the flexibility of their subtalar joint. Now, the surgeon, if you didn't notice this, he performed a medial displacement calcaneal osteotomy because he did recognize that the patient needed more than just the Lapidus procedure. So again, think about where the patient's at. She had the initial surgery, Lapidus, and medial displacement calcaneal osteotomy with the screw. Screw became painful, so the screw was removed. So she's had 2 surgeries, and after that, she still has the same pain in her first MPJ. So here we have relaxed stance position, how the patient normally stands, and then neutral stance with their hind foot placed back into normal alignment. And we look at the bisection of the talus, how it's gone from its medial to the first metatarsal bone. And then once the talus is realigned back on the calcaneus, then we see how the bisection is within the first metatarsal bone. It's normal. Also, take a look at the fibular sesamoid, how it's peaking laterally. And then once we realign the hind foot, it's positioned exactly where it's supposed to be under the head of the first metatarsal. Okay, so here's the lateral. So we see the talar declination as a pathologic, and look at the alignment of the screws. And then once the patient places their foot back into neutral position, look at the alignment of the screws, and then how we have elevation of the navicular and a really good normal talar declination angle. So what is your treatment going to be for this patient? Well, instead of doing all of these other crazy procedures, why can't we put that titanium stent into the sinus tarsi to maintain the alignment of that? And that's what the patient had. So now we have the pre-op and the post-op patient fully weight bearing. We've lifted up the navicular and we've decreased the forces acting on the first metatarsal bone. And in addition to this, and we have to think about that there's something else connected proximally to the talus, and that's the rest of the body. So the patient was also experiencing problems with their knees, hips, and back. And by stabilizing the foundation joint to their body, we also help the rest of their body. So here we can see pre-op, post-op with the hypercure stent placed, and how we've brought the bisection exactly back where we want it to be. So the moral of the story here is that if we were able to treat this patient early, and probably the only procedure we needed to do to help her first MPJ was to insert hypercure into the patient's hind foot when they have a mild hallux ductovalgus and metatarsus primus varus deformity. Maybe then we can have a better preventative measure to prevent it from getting worse, or we can perform both at the same time if needed. So that was my case study for that one. Thank you.
Thank you, Dr. Graham. I think I also had a exactly similar case. I think I had shown it to you during one of the previous presentations. I think it was also a child with a hallux valgus, and all I had to do was insert the hypercure, and everything corrected, the whole of it. And this boy became so very playful that even before the removal of the staples, he had gone to play badminton and all that. So the only complaint the mother had was that tell him not to play. So that was the thing. That Dr. Lucas, any case that you would like to show us, any learning points that you would have to? Dr. Lucas?
Can I ask a question?
Yes, sir.
Graham, how did you come with this idea, which you said out of the box? She's not practiced in orthopedics with that strength. What was the trick, or what stimulated you to go in that direction?
Yep. So I was going to be a foot surgeon since I was 7 years old. And like I was talking about that earlier before the conference started. And so this is, my passion is foot and ankle surgery. But, and so in the US, there's the 2 ways to becoming a foot and ankle surgeon. It's the podiatric way and the orthopedic surgeon way. And the podiatric way is just a quicker pathway. And we have the same surgical training and all of that. So, but one of the things with being going the podiatric route was studying the orthotics. And of course, they say, well, we can cure everything with arch supports. But I was finding in my practice, this is not true at all. And patients were walking right over them. And then also having the hindfoot surgery experience of performing all of the big surgeries and saying that, yeah, this is great. And it definitely works, but it just seems like there's got to be an in-between option. And I heard about the other sinus tarsi implants that were being used years ago, but they had a high failure rate, and I was using them and I wasn't happy with the success rate. Again, for the first 2 to 3 years, patients did very well, but then once they hit that 2 to 3 year period or longer, then there's a higher chance that the device had to be removed. And so I just took a look at, why is it, because I'm a critical thinker, why are these devices being removed? And then it was so obvious because of the alignment. They were going from lateral to medial. And so the talus is just smashing on them versus with this design that the Hypercure is stabilizing it. And so now the talus is gliding over it versus that trauma onto the implant. So it really took me only about 10 minutes to get the overall design, because all we're doing is taking this negative space, turning it into a positive space, while still working with the overall biomechanics of the talotarsal joint. I can tell you that the first case that I actually put a Hypercure to the patient, I did not sleep too much the night before because of fear that I'm going to kill the patient tomorrow. But after I put the implant in, I was like, wow, this is amazing. This is great. So. Yeah, so it's been, I never, ever in a million years thought that I would be sitting in the chair that I am and lecturing and publishing. I was just going to be performing foot and ankle surgery, working for somebody else.
What others tell you to do.
What other studies did I do?
No. If you had not done this, you would have been doing what others told you to do.
Oh, that's right. That's right. Yeah. So, and that's one of my problems is I always am thinking and I'm a critical thinker. So, yeah. So it's great.
Initially, did you have lysis around the screw? Initially,
I have what?
Lysis around the stent.
I have not. It's possible that can happen, but no, we haven't really seen any kind of like I said, fractures or anything like that. Usually, there's going to be more of a strengthening of the cortical bone versus a weakening of it. So I do know that there was one case where the surgeon thought that they had a lysis that was occurring below, but then once they looked at the previous X-ray of the patient, it was pre-existing before the implant was put in. So yeah, so we haven't seen that at all. So it's scary when surgeons, and I've put them in professional athletes, and they come to you and you're performing foot and ankle surgery on them, but they're very happy afterward. Because their muscles are working more efficiently, and it definitely increases their game. So they're very happy. So,
thank you.
Yeah.
The particular type of rehab you put on them post-operatively for gaining the maximum functional outcome?
I'm sorry, the audio is not too clear. Yeah.
Any particular way of rehabilitating these patients post-operatively for the?
Yep. Yeah, that's the procedure takes about 10 to 15 minutes to perform, and you can't really make it last longer than that. It's a fast procedure. So you think that, well, the recovery is going to be equivalent. It should be a fast recovery, but it's not necessarily so, because people have been walking one way their entire life, and now we're correcting them. And it's not like we can just put in a small one and bring them back in 6 weeks, put in a slightly bigger one, and gradually build them up to the correction that they need. And every single patient is different with their recovery, where, like Dr. Joy was saying, like some patients, within the first couple of days, they're already walking around like not even no surgery was performed. They're very happy. And then you have other patients that have a mild deformity. I mean, they're still a candidate for this, don't get me wrong. And they're just limping around, and you're just scratching your head saying, why is this patient having such a longer recovery when we would assume that they would have a fast recovery? but everybody has different pain tolerances. Some surgeons, they have a very conservative approach in post-op management. Well, they will have a patient non-weight bearing for 3 to 6 weeks. And then they have them going for physio and whatever else. Then you have other surgeons that 3 days out of surgery, the patient cuts the dressing off and they just put a covering over the incision until it's healed, and they're walking back into their regular shoes. So you almost have to be a little bit, read your patient. Is this patient going to be compliant? Because that's what I always tell patients, is you have to listen to your foot. If your foot's hurting you, that means you're doing too much. So listen to your foot. And people that say, well, just keep going through the pain. No, pain is there to tell you as a precaution to say something's wrong. So you have to take it easy. So they have to ice their foot. Usually it's more like that afterward that they've had an ankle sprain. So I have the implants in my feet. I've had them for over 10 years. And literally about 10 days after I had the one foot done, I was flying from Michigan to Florida to give a lecture at a foot and ankle surgeons conference 10 days later. So my daughter also has them in her feet for at least 12, 13 years now also. So no problem. Yeah. So, and then the other thing too, just to kind of go on from that, is if other surgical procedures were performed, so if you did a lateral column lengthening or MDCO, obviously that is a more aggressive procedure. So that post-op recovery is going to dictate the other one.
Right. Okay. So can I just show just one case where I performed an MDCO with the OTTS? I think, is that okay?
Yeah, great.
Yeah, okay, let's just do that. Okay, so visible?
Yes.
Yes. Okay. So this is a 37-year-old male who was complaining predominantly of pain in the knee. So this is what I was, which has been emphasized time and again. It's not necessarily only the foot that the patient would complain of. He would also complain of pain elsewhere in the body too. So this patient had pain in the right knee, and of course he had medial foot pain also. So the thoughts which came to me when I saw him were that, and his feet were like this, and it was the right side which was extremely painful for him. The thoughts which did come to me was, with the amount of swelling that we can see there, was whether there was an involvement of the tibialis posterior on the on the right side. And in addition, because of the malposition per se, I think he had an issue with the knee too. So this was the thoughts with which I started exploring and investigating this patient, and performed the Salzman view on him. This is the Salzman view. We can see that he had a calcaneus. If you can see that the septalar joint is fairly okay, the alignment of the septalar joint seems to be fairly okay, but his calcaneus seems to be turned out like that. So I felt that he would be, and that's the tibial axis. So this patient I felt would be an candidate for an MDCO, because I felt that the calcaneus definitely needs to be realigned in addition to getting the septalar joint correctly. So with that intent in mind, I started off with the patient. On the medial side, of course, I had to explore to see what was wrong. We had to go in there, and I found that I was actually thinking that I might find the tibialis posterior is completely torn, or at least badly, or at least there would be some areas of degeneration. But what I did find was that the tibialis posterior was extremely hypertrophied in this patient. It was hypertrophied. So I felt that this almost more than a centimeter. I think I had never seen a tibialis posterior which is this big and thick. So what I feel is that because of the repetitive weight bearing on the medial side on a malpositioned foot, I think the tibialis posterior is reacting by hypertrophying and trying to do part of the job which normally the deltoid and all would have been doing in this patient. So this was more like a response rather than the cause for the pain on the medial side. And I went ahead with the medial displacement calcaneal osteotomy, which I had planned for him. So that's the osteotomy I performed, and I had used a plate in this patient. This is one of the Arthrex plates, which has got a fixed displacement, which you can either a 5 mm, 7.5 mm, or a 10 mm displacement, and a 7.5 is what I had chosen for this patient. And once I performed that, that's the alignment of the foot which you can see. So you can see that the calcaneus is almost come back to a normal position, and that's the position in which the tibia is. So it was almost a straight line which had happened there. So with the medial calcaneal osteotomy, of course, I added up EOTTS for him, and once I added up the EOTTS, the whole the talus and all which were subluxating, all the recurrent dislocations stopped, and we got a perfectly aligned foot in this case, and also an arch which was formed right on the table. And so that's the immediate post-op X-ray for this patient. You can see that the talus and all had actually come back to the same position that we had intended it to be, and also the calcaneus also was very well aligned. Soon after the plaster removal, because this I had also performed an MDCO, so I kept him in a plaster for some time, and that is his position at about 6 weeks time, and gradually allowed him to start weight bearing. Those were his X-rays at that point in time, allowed him weight bearing, and at the end of about 6 months is when I saw him next, and I told him to perform a single heel raise test at this stage, and that was what he was able to do. He was able to perform a dual heel raise test, and when I asked him to perform a single heel raise test, he was actually able to perform it so well. You can see that you can see the gastronymics, which has completely hypertrophied now and which has come back to normal. If you remember his first pre-op picture, this was completely wasted. So, and the tendo achilis also is very well aligned, and you can see that he is able to perform a single heel raise, and the calcaneus is also inverting. So, which means that we have restored his hindfoot mechanics to the maximum possible. And when I tell him to walk, so he's telling us that this is the one which is corrected. So he's walking so comfortably that he doesn't have any pain at all. And that is his X-rays. So you can see that the calcaneus is completely well aligned, and you can see that the subtalar joint positions is restored, and the tibia is also very well restored. So this is one of the 6 months follow-up that we have, and you can see that both the Meary's angle and all of it is well normally aligned for this particular patient. So this is what I did. Any comments about this? Any comments, Dr. Graham, Dr. Lucas? Did I do the right thing? Did I do? Could have done something better?
No, that's great. Excellent correction. I mean, you can't complain about that. So that's great. Really good.
And one other patient that I had, this is a 41-year-old lady, and this is something which we see very often. We see patients here with a lot of hallux varus deformity. It's almost like a skew foot that we see, and that's the pes planus that she had, and that's how her foot is positioned. And it has started getting painful now. So I had seen her some 2 years prior to this particular incident, and at that time I had also suggested that she undergo a surgery, but she did not come back to me soon after. And now only when it became extremely painful is when she has come back, and she is having pain both at the medial aspect of the ankle per se, and also the foot. Now the foot has become, this deformity, the hallux varus deformity, has also become quite rigid, and this is how she is able to walk. You can see the deformity and as well as the difficulty with which she has been walking. And just at 41, and she also is probably a single parent, and she has to take care of a child also. So many things in mind. So got her X-rays done. So you can see that the talus is declined completely. The whole it's looking downwards, and the angles were drawn for her also, and you can see that it's a negative Meary's angle of about 15 degrees. So normally we should either have a 0 or a positive angle. In her case, it was a negative angle of 15.4 degrees, and that's the calcaneal pitch, which was almost about 17 degrees. So this would indicate that the calcaneus is not the cause for a deformity, but the deformity is happening more at the talus level, or due to something which is a little beyond the calcaneus. And with that in mind, and with a picture like this, and with this completely fixed subluxated joint like this, I thought that she might be an ideal candidate. I actually discussed this among the foot and ankle group also, and all of them suggested to me that you go ahead with fusion, go in with talonacular fusion for her, and that with that you will be able to restore her medial mechanics well, and also go in with an MTP fusion for her. And with angles like this of 56 degrees of a varus, I thought that it would probably be the best solution. And with that in mind, I took her up for surgery, opened up on the medial side. And when I opened up on the medial side, I found the tibialis posterior to be intact. And when I looked at the joint also, uh, it looked so nice and tidy that I did not feel like going and fusing this. So, but and I tried to see if I can restore the biomechanics, if I am able to lift up the talus, which I did by means of a this thing over here, a spike over here, and I tried to lift it. I was able to correct that, but unfortunately, I had not planned for this, and I had not planned for an EOTTS. So if I had, I probably would have gone ahead only with that, used an EOTTS on that side, and go on with the fusion for the MTP which I had planned. So what I did, I just kind of thought, and I used a bone graft. I used an allograft which was available to me. I pushed it in very similarly. I shaped it almost like a EOTTS stent, and kept it in the sinus tarsi, and used a K-wire on top of it, repaired all the medial structures, used a K-wire on top of it on the medial side just to keep this talonacular joint stabilized in the position that I wanted to, and performed an MTP fusion for her. So that was the correction which I obtained on the table. That's the correction of the hallux varus also, and a good correction, both which was documented by means of the X-rays too, and the talus also has restored to the normal position, and the flat foot also was completely corrected just with this. Almost a 6-week follow-up is what I have on her. I don't have too much of a follow-up on her, so that was the corrected position that I have obtained. And this is when she came back for follow-up once the plasters were removed, and I was just about to start weight bearing for her, and I told her that I'll remove the K-wire which was done at this visit. And that's the correction which I've been able to obtain. The flat foot is completely corrected, the varus is completely corrected, and she has started weight bearing. So let me stop at that. I'll just stop my share. So any comments on that, Dr. Graham, Dr. Lucas, or Krishna, or anything, anybody, what would like to tell with regard to this particular patient?
Yeah, I mean, looking at the pre-op X-ray, that's a really severe talar declination deformity. And so that's that would be potentially pushing the limits of the kind of correction that we can get with hypercure. But I mean, you never know. I don't know how long the bone graft is going to last, which is why we make the implants out of titanium, so that it's going to definitely last longer. I think that after a while, she's probably going to lose some correction, but you can always go back and remodel that space and put a hypercure in. But,
yes, I think so. Yeah, I think that is what I could do, because on that day on the table, and I had not planned for it. So, so this was the best in that position. So I did that. And with regard to the MTP fusion, I think there would have been no other choice, isn't it? I think MTP fusion was probably the best thing that it could do, and it was a fixed deformity. It was just not correctable. So that was the thing to do.
Yeah,
okay,
for sure.
Okay, right. And Dr. Lucas, anything from your end?
Yes, I'm amazed by that case, really amazed. So I probably I would go for double fusion with her, with that lady. Probably I wouldn't start with anything else, but the results are great. Really, congratulations for you.
Okay, thank you so much. So that was the intent with which I had gone. That was the reason for the medial incision. But then I thought I'll just do this and see. Okay. And Dr. Krishna, I think.
That's fine.
Okay, right. Krishna, you had a case. You said that's the tarsal tunnel. You said we could just.
I'll present that.
Okay.
We have time. We have time.
Ajay has to take the call.
Yes, sir. I think it's 9:40. I think, is it okay if we just see this one case or?
It's a short case.
Yeah, just go ahead. I think just make a short presentation of that.
Yeah.
Can see, right? Yeah,
Yes, we
hear.
can. Yes, good.
So this lady, a 45-year-old homemaker, came to me with the pain around the medial side of the right ankle. Now she had this pain for last 6 months, aggravated for the last 3 weeks. Even it was so disabling that walking or standing for a long time in the kitchen was a problem. So there was no comorbidities in this lady with no diabetes specifically and hypothyroidism. Now there was a pain and swelling around the right ankle all along the tibialis posterior tendon, and this was her alignment. And the single raise test was possible, but it was painful. So when weight-bearing radiographs were taken, there was flat feet with the 7 degrees of calcaneal pitch angle, and near-raise angle was reversed. And there was not much of talar uncoverage. So with this in mind, I went for a conservative trial of medial arch support, and I told her to go for an orthosis custom made. I told her to review after 3 weeks, but in fact, she came to me with an exacerbation of symptoms in 2 weeks' time with severe pain. At this presentation, there are a few facts which I found. The pain was radiating along the foot, and there was tingling at this presentation, and the Tinel sign was positive. So I went ahead and went for an MRI and nerve conduction study. The nerve conduction study showed right tibial nerve neuropathy, and MRI surprisingly showed me a ganglion cyst, which is compressing neurovascular structures. And there was a spring ligament tear also, as well as there was a posterior tibial tendinopathy. So there was a ganglionic cyst, there was a tendinopathy of posterior tibial tendon, and the partial tear of spring ligament. Now, there was a management dilemma here. Now, whether to go ahead with the tarsal tunnel release or to tackle both flat foot as well as tarsal tunnel release. I just wanted an opinion at this stage.
Dr. Graham, Dr. Lucas, I think what would be ideal for him to do at this stage?
So, yeah. So one of the things definitely is, again, and I hate to keep going back to all of this, but we know that tarsal tunnel syndrome, one of the major etiologies is hyperpronation. Hyperpronation is caused because of the subtalar joint instability. And there's been some papers published showing that with hyperpronation, it increases the strain within the tarsal tunnel and the portopetus. I also published some papers in JFAST showing both. There's two separate papers. Number one was decreased forces within the tarsal tunnel and portopetus by stabilizing the hindfoot with hypercure. And number two was the strain on the nerve, because usually we only think about decompressing the tarsal tunnel because of the increased forces, but because of the hyperpronation, there's actually an elongation that happens of the posterior tibial nerve. So that's why for me, I want to see the x-rays, look at her hindfoot alignment and start there. Because again, I would love to say, let's just get her on some other conservative care, but no matter what you do, those same exact compressive and elongation forces are going to be acting on the tarsal tunnel when she's walking.
Yeah. So I had this dilemma. So I went back to literature, what the literature told. As rightly told, when we come to the etiology, now valgus heel per se can cause tarsal tunnel syndrome up to 8% of the cases. Now there is a this is the biggest number of patients, 11 patients who had pes planus, where the tarsal tunnel syndrome in combination, where this was managed by orthotic footwear. But there is a study, as Dr. Graham rightly told, where it's a cadaveric study where surgically created pes planus resulted in increase in the pressure over the tarsal tunnel, resulting in aggravation of the symptoms. So this was a paper told that you should avoid the tarsal tunnel release. But the catch was in this patient, it is not the pes planus which was causing the tarsal tunnel per se, because there was a there is a space occupying lesion in the form of a ganglionic cyst, which tells that by decompressing it, you can almost relieve the symptoms. So I had these two things in mind. I had a talk with the patient, and since the symptoms were severe, because she presented to me within 2 weeks of giving the orthotics with the severe tingling and numbness. So I had staged this procedure thinking that I will do a decompression of the tarsal tunnel, because there was a ganglionic cyst which was compressing, and the release was done till the fascia of the adductor hallucis, so that the lateral and medial plantar nerve fascia also is released. And I counseled her to go for a rehab, and then if symptoms recur, then we will think about the correction of the foot. So patient was followed up at 2 weeks for suture removal. At 6 weeks, partial weight bearing was started, and I had given a medial arch support only in this time, and 12 weeks full weight bearing with a stretching program, rigorous stretching program was given. And at 6 months, I had seen her where the tingling had gone completely, and at 1 year, patient was absolutely symptomless. Patient is vigorously doing these exercises and wearing this footwear with a medial arch support. And this was the latest. And 2 weeks back, she had come to me for, she's a very dedicated patient, whatever, some knee pain she had come, but absolutely symptomless now for 3 years. So I had given an option, if it recurs, then I have to think about correcting the deformity. But patient was absolutely symptom free for 3 years now.
That's great. It's kind of surprising that there is literature that is completely against the tarsal tunnel decompression, like you said. And for me, it's because, we have a secondary thing that's going on. So your patient is very fortunate, and probably because maybe of the stretching, the shoe gear, different things that you've given her, that she's asymptomatic at this point. So that's wonderful. Glad. I'm very happy. Yeah. Good.
Thank you.
Yeah. Thanks, Krishna. I think any more comments, anything, anywhere?
No questions from the audience so far.
Okay.
Can we ask the company to speak?
Yeah.
Bharat Raju can coordinate.
Pharmaceuticals just wants to make a few comments. Mr. Satish.
Yeah. Yes, sir. Yes, sir. Good evening, doctor. On behalf of MQ Pharmaceuticals Limited, we extend our deep gratitude to Karnataka Orthopaedic Association, our president Chandrasekhar sir and Bharat Raju sir, and very sincere thanks to Satish sir and Vamsi sir for having given this wonderful platform and an opportunity. Thank you all for being here today and taking the time out from your busy schedule to attend this program. So to talk about our company MQ, we work as a rehab champions to support ortho fraternity by offering an integrated product basket to take care of bones, joints, and muscles. So we assure that we at MQ will always be happy to collaborate with medical fraternity on activities. At this juncture, we salute all medical fraternity for saving lives, everyone's life at this time. So thank you, doctors. Have a great evening and day ahead. So over to you, sir. Thank you.
Thank you, Satish. Now Dr. Bharat sir will make the final remarks. Dr. Bharat sir.
Good evening, everyone. It was a wonderful evening, enlightening us about best planners, flat foot. And I appreciate Dr. Chandrasekhar's initiative in conducting these webinars on a regular basis. I thank Dr. Graham and Dr. Lucas for taking time off from their busy schedule and joining us and enlightening us about their innovations and their work. I also thank Dr. Ajay and Dr. Krishna Prasad for being a part of this webinar. Special thanks to Dr. Satish Shervegar and Dr. Vamshi Krishna for coordinating and organizing these webinars. I also thank the panelists, Dr. Prithviraj Malli and Dr.
Prakash
Wali from Belgaum. Thank you, sir. And hope we'll be associating in future also, Dr. Graham and Dr. Lucas. Thank you again. Have a good evening.
Thank you, Bharat Raju.
Thank you, sir.
Thank you. We'll close the session. Thank you all. Good night.
Thank you, everyone. Have a great night. Bye-bye. Great job. Thank you.
Thank you.